First of all, I want to say I'm really, really glad we had the opportunity to take a break before we get into the discussion on quality measures. For many people, quality measures is a little bit of a more dry topic and drier than the RAI and the MDS. So I'm hoping that you'll be able to follow along with me and share my excitement in the quality reporting program and the quality measures. First of all, I also want to thank Bridget and Econometrica for all of their guidance, and CMS and my colleagues for all of their support. Clickers. Did I get it? All right. The acronyms in the presentation have been reviewed by Bridget and Terry. There are acronyms in each slide deck that are relevant to each of the presentations. Okay, maybe it doesn't work. Okay, thank you. The objectives of the program today are to become familiar with the quality measures that are currently publicly reported in the SNF QRP, as well as quality measures that were updated for the SNF QRP for FY 2020 reporting. To understand some of the key components of the QRP quality measures and how they're calculated, and to gain an understanding of the data submission deadlines and the reporting timeline for 2020 and subsequent years. Let's start with the assessment-based quality measures. We'll begin with a review of the assessment-based QRP quality measures. An important note is that although some measures in the SNF QRP have the same name as a measure used in the Nursing Home Quality Initiative and the 5-Star Program, the measure specifications for the QRP measures may be quite different. We're focusing this presentation on the SNF QRP Quality Reporting Program. To better understand how the measures are calculated, it'll be useful to understand a few key concepts. At this time, the SNF QRP only applies to skilled nursing facility residents in a Medicare Part A stay. We do often get questions about that, so I just want to reinforce that it only applies to residents in a skilled nursing facility in a Medicare Part A stay. The first important concept in the SNF QRP is stay. For the purposes of the SNF QRP, the Medicare Part A stay includes consecutive time in the facility, starting with the Medicare Part A admission assessment, or the PPS 5-day, and that may be combined with an OBRA admission assessment or standalone, and through the Medicare Part A PPS discharge assessment. That also may be combined with an OBRA discharge. The Part A PPS discharge is where A0310H on the MDS is coded 1 or yes. Or the stay may also be related to a Medicare Part A stay 5-day with a matched death in facility tracking record. The second concept is look-back scan. The look-back scan is conducted to review all qualifying reasons for assessment within the Medicare Part A SNF stay to determine whether certain events or conditions occurred during that stay. The look-back period consists of the entire Medicare SNF Part A stay relevant to the resident. The next key component that I want to review is the denominator. Welcome to Math 101. The denominator is the total number of Medicare Part A SNF stays that do not meet the exclusion criteria for each facility. So the denominator is a Medicare Part A stay. The numerator is the total number of Medicare Part A SNF stays in the denominator that meet the criteria for inclusion in the measure. An exclusion is a Medicare Part A SNF stay that is not included if the exclusion criteria are met. Pretty straightforward for an exclusion. The observed performance is an unadjusted score calculated by dividing the numerator by the denominator, and covariates, which are variables used to adjust scores for measures that are risk adjusted. These are general definitions or concepts, but can vary by measure. For example, for the claims-based measures, such as potentially preventable readmissions or discharge to community, these definitions may be a bit different. There are two types of SNF stays. Now that you have a better understanding of this concept of a stay, there are two types of stays. The PPS discharge matched with a Part A PPS admission, so a Part A PPS 5-day with a Part A PPS discharge is a type 1 stay. The concept of stay in this relationship is really important because that is how a quality measure is calculated. It's based on the stay, the whole stay from the 5-day to the discharge. And then there's a type 2 stay, which is a PPS 5-day with a death and facility tracking record. Our first Slido. So let's do a knowledge check using Slido. I hope you have a good short-term memory because the question is, what is a type 2 stay? Ooh, we've got Slido going and I haven't even asked the question, but I'm really excited that you're excited too. A SNF stay with a PPS 5-day assessment and discharge tracking record. B, a SNF stay with a matched pair of PPS 5-day assessments and PPS discharge assessments. C, a SNF stay with a PPS 5-day assessment and no death and facility tracking record. Or D, a SNF stay with a PPS 5-day assessment and a matched death and facility tracking record. Oh, outstanding. You selected D, the vast majority selected D, and that is the correct answer. A type 2 SNF stay is a SNF stay with a PPS 5-day and a matched death and facility tracking record. Nice job. There are currently 8 assessment-based measures in the Skilled Nursing Facility Quality Reporting Program. The first 2 measures were implemented in October 2016. They are application of percent of residents experiencing 1 or more falls with major injury, and application of percent of long-term care hospital patients with an admission and discharge functional assessment and care plan that addresses function. The remaining 6 measures are Skilled Nursing Facility Functional Outcome Measure, change in self-care score for medical rehabilitation patients, SNF Functional Outcome Measure, change in mobility score for medical rehabilitation patients, SNF Functional Outcome Measure, discharge self-care score for medical rehabilitation patients, SNF Functional Outcome Measure, discharge mobility score for medical rehab patients. And if you don't mind, I'm just going to refer to them as change in self-care, change in mobility, discharge self-care, and discharge mobility. Changes in skin integrity, post-acute care, pressure ulcer injury, and drug regimen review conducted with follow-up for identified issues, post-acute care, skilled nursing facility quality reporting program. And if you don't mind, I'll refer to that one as DRR. We'll be going over the new measures later in the presentation. In the FY18 final rule, it was finalized that the pressure ulcer measure, percent of residents or patients with pressure ulcers that are new or worsened short stay, would be replaced in the SNF QRP with the pressure ulcer measure, changes in skin integrity, post-acute care, pressure ulcer injury, beginning with data collection on October 1st of 2018 for the SNF QRP. So let's start with the measures that are not changed or new. Oops, could you go back one, please? The first is the application of residents experiencing 1 or more falls with major injury. It's an application of a measure that was endorsed by the National Quality Forum, or NQF, for the long-stay nursing home setting. The measure was finalized in the SNF FY16 PPS final rule for the QRP, and data collection began on October 1st of 2016. For those of you who have been in the MDS world, as I have for a very long time, considering all of the changes that we've experienced in SNF PPS, PDPM, and the QRP, October 1st of 2016 feels like a lifetime ago. This QRP quality measure reports the percentage of Medicare Type 1 stays where 1 or more falls with major injury were reported during the SNF stay. For the calculation of the measure, the denominator, which we now know is the total number of Medicare Part A SNF stays that don't meet the exclusion criteria, is the total number of Medicare Part A Type 1 stays with one or more assessments that are eligible for a look-back scan. So, with the denominator in mind, the numerator is the total number of Medicare Part A Type 1 SNF stays from the denominator with one or more look-back scan assessments that indicate one or more falls resulted in a major injury. And if you recall looking at your quality measure reports in the QRP, it shows 4 quarters of data. And all stays are included in the measure if the resident had multiple stays during the target 12 months. The numerator divided by the denominator times 100 will give you your percentage. And for this measure, for falls with major injury, a lower score is preferable. So to get a little bit more technical, this information comes from MDS item J1900C, falls with major injury coded 1 for one fall, or 2 or more falls with major injury since admission, entry, re-entry, or prior assessment. The falls measure is unique in that it includes OBRA assessments in the look-back scan. A0310A equal 1, 2, 3, 4, 5, 6, any OBRA discharge assessment, any or all PPS assessments, including any PPS discharge assessments. Next, we're going to look at the SNF QRP quality measure, application of percent of long-term care hospital patients with an admission and discharge functional assessment and care plan that addresses function. This is a cross-setting post-acute care function quality measure that is an application of a quality measure that was endorsed by the NQF in the long-term care acute hospital setting. As a cross-setting measure, it was adopted for the skilled nursing facilities, home health agencies, inpatient rehab facilities, as well as long-term care hospitals. This measure began collecting data in October 1st of 2016 also. What's unique about this measure? It considers both type 1 and type 2 SNF stays in the calculation of the measure. The measure is also introduces us to the concepts of a complete and an incomplete stay. This is a really important concept, and we're going to review that in just a few minutes. This measure reports the percentage of Medicare Part A SNF stays type 1 and type 2 with an admission functional assessment on the PPS 5-day assessment, the completion of all required data elements on that PPS 5-day, at least one goal that addresses function, and a discharge functional assessment on the PPS discharge for the completion of all required data elements for a complete stay. For an incomplete stay, the issue is that for an incomplete stay, which we're going to learn in just a few more minutes, is that there is no capability for us to complete the items on the PPS discharge. It will be grayed out for an incomplete stay. So for an incomplete stay, you're still required to complete all of the items on the PPS 5-day and at least one goal. So you need to make sure that the coding is correct in order for that incomplete stay to be properly represented and for GG to be grayed out in your software. The other important concept I want to talk about here is that at least one goal that addresses function must be coded on the PPS 5-day for either one self-care or mobility item. The remaining discharge goals can be dashed, with a dash in this allowed instance not affecting your annual payment update. You may, and we encourage you, to include more than one goal. You would want to include as many goals as are appropriate for your plan of care. So let's take a break from the little minutia, we'll call it, of the quality reporting program and talk about the documentation. So where does the documentation come from to support the coding of the GG items? The answer is that the data entered in GG should be consistent with clinical assessment documentation in the resident's medical record, and therapy and nursing notes may be used to support coding. Let's now look at an illustration of how the quality measure application of percent of long-term care hospital admission and patients with an admission and discharge functional assessment and care plan that addresses function. And please forgive me, that's a mouthful to say over and over again. Let's look at how it's calculated. Let's look at the denominator, or our potential measure population first. The denominator is the total number of Medicare Part A, Type 1, and Type 2 stays, with a Medicare Part A SNF stay end date, or in A2400C, during the measure target period. The numerator looks at the completion of all of the required data elements we just reviewed for a complete stay, admission performance, at least one goal, and discharge performance, and if the resident had an incomplete stay, all the required GG admission performance data elements and at least one goal. Once again, the numerator divided by the denominator times 100 will give you a percentage score. And for this measure, a higher number is preferable. So let's look at the definition of an incomplete stay. An incomplete stay is an unplanned discharge where A0310G is coded as 2, unplanned, either on the OBRA discharge, with a discharge date of A2000 on the same day or the day after the end date of the most recent Medicare stay, or discharge to acute, psychiatric, or long-term care hospital, where A2100 equals 03, 04, or 09, as indicated on an MDS discharge, with a discharge date in A2000 on the same day or the day after the end date of the most recent Medicare stay, or your SNF PPS Part A stay less than 3 days, or if the resident died during the SNF stay, Type 2 stays, which are SNF stays with a PPS 5-day and a matched death in facility tracking record. Remember, for residents with complete stays, all of the required discharge, admission and discharge GG items must be completed, as well as at least one goal. For residents with incomplete stays, all the self-care and mobility discharge performance codes are required on the PPS 5-day and at least one goal. Another Slido check. All of the following are determinants of an incomplete stay except A, death, B, SNF Part A stay greater than 3 days, C, discharge to acute, psychiatric, or long-term care hospital, D, unplanned discharge. Well, with a few stragglers, we have a few more coming in, but the overwhelming majority seems to agree with the correct answer, which is B, a SNF Part A stay greater than 3 days. Now we're going to go into a little more detail on the measures that were recently added to the SNF QRP, starting with the functional outcome measures. The SNF QRP added 4 functional outcome quality measures to address the requirements of the IMPACT Act, domain of functional status and cognitive function, and changes in function and cognitive function. The 4 risk-adjusted outcome measures are change in self-care score, change in mobility score, discharge self-care score, discharge mobility score. These measures are unique in that all 4 of these functional outcome measures are risk adjusted, as well as being type 1 stays. For the change in self-care score, the measure estimates the risk-adjusted mean change in self-care score between admission and discharge for Medicare Part A type 1 stays. And expected scores are factored into the risk-adjusted mean change scores. There's not a simple form for the numerator and denominator. The change in self-care score is calculated as the difference between the discharge self-care score and the admission self-care score. The target population is the number of Medicare Part A SNF stays, except those meeting the exclusion criteria. As we mentioned, this measure is risk-adjusted, and higher scores indicate greater independence. The self-care change score uses 7 GG self-care admission and discharge performance items from the PPS 5-day and the PPS discharge. They are eating, oral hygiene, toileting hygiene, shower, bathe self, upper body dressing, lower body dressing, putting on and taking off footwear. So you'll notice on the slide that we provide the references on the PPS 5-day and the PPS discharge. For example, for eating, GG0130A1 on the PPS 5-day and A3 on the PPS discharge. This measure is calculated using the 6-point rating scale because in order to calculate the change, you need to address numerically how to calculate that change. So it includes the 6-point rating scale, 01 through 06, or independent through dependent, and all of the activity not attempted codes. The exclusions for the change in self-care score are when there's a Medicare resident with an incomplete stay, if the resident is independent with all self-care activities at the time of admission. So that means that they must be independent in all of the self-care items in order to exclude that resident from the measure. If the resident has the following medical conditions: coma, persistent vegetative state, complete tetraplegia, locked-in syndrome, severe anoxic brain damage, cerebral edema, or compression of the brain. If the person is younger than 21 years old, is discharged to hospice or is receiving hospice while a resident, did not receive physical or occupational therapy services on the PPS 5-day assessment, or is not a Medicare Part A beneficiary. I want you to pay attention to these exclusions because you're going to see them 3 more times with a slight variation. So maybe I should quiz you on what's different about the exclusions rather than tell you about them. The calculations for the admission and discharged observed self-care score uses the following procedure. I want you to pay attention to this as well. You're going to see this 3 more times. If the code is between 01 and 06, then you use the code as the score. If the code is an activity not attempted code, an 07, 09, a 10, 88, or if the self-care item is skipped, dashed, or missing, then the item is recoded to 1, and the 01 is used as the score. Sum the scores of the admission self-care items to create an admission self-care score for each stay level record, and the scores can range from 7 to 42, with a higher score indicating greater independence. And the first time I looked at this, I said, well, why 7 to 42? Because there are 7 admission performance items and discharge performance items. The minimum code is an 01. 01 times 7 is 7. And the highest is 06. Welcome to my secret. The observed self-care change score is a self-care discharge score minus the admission score. It's calculated for each resident stay. And the facility level observed self-care change score is the average of the observed self-care change score for each resident stay, except those that are excluded. For the expected self-care change score, resident risk factors are used to calculate the expected self-care change score for each resident stay. Some examples of risk factors include age, prior functioning, prior medical condition, and comorbidities. There are many others. If you're interested in what all of the risk factors are, they are in the SNF QRP QM User's Manual. The facility level average expected self-care change score is the average of the expected self-care change score for each resident stay. The measure calculations used in the change function measures use both observed score and expected scores. After you calculate the observed score for each resident stay, the next step is to calculate an observed change score and then the expected change score for each resident stay and for the facility. And to get the expected change score, you need to apply covariates or risk adjustment. So you may be able to see an observed score in the change measures before risk adjustment. Since the measures were implemented, additional time and data have been needed to calculate the risk adjustment covariates. And your review and correct reports have not displayed the complete or final score because they are not yet risk adjusted. Now let's look at the functional outcome measure, change in mobility score. We've just reviewed change in self-care score. You'll find many similarities. This measure estimates the risk-adjusted mean change in mobility score between admission and discharge for Medicare Part A Type 1 SNF stays. Once again, there's not a simple form for calculating the numerator and denominator. The change in mobility score is calculated as the difference between the discharge mobility score and the admission mobility score. Once again, target population is the total number of Medicare Part A type SNF stays, except those that are excluded. The measure is risk adjusted, and higher scores indicate greater independence. The mobility change score uses 15 Section GG admission and discharge performance items, again from the PPS 5-day and PPS discharge. They are roll left and right, sit to lying, lying to sitting on the side of the bed, sit to stand, chair, bed to chair transfer, toilet transfer, car transfer, walk 10 feet, walk 50 feet with 2 turns, walk 150 feet, walk 10 feet on uneven surfaces, 1-step curb, 4 steps, 12 steps, and picking up object. So there are 15 Section GG self-care admission and discharge performance items. The response codes, again, include all of the 01 through 06 6-point rating scale items, all of the activity not attempted codes. I'm smiling because I'm having support from the technical staff to change the slides. The clicker is not working as well, and I'm not sure that I'm pressing the right button. So first of all, I want to thank all of you for your patience as the slides are advancing, for your patience with me as I'm pressing perhaps the right button or the wrong button, and for the technical team. Thank you. The exclusions for change in mobility are the same as the exclusions for change in self-care, except that the stay is excluded for change in self-care if the resident is independent in self-care, and the stay is excluded for change in mobility if the resident is independent in mobility. However, the exclusion only applies if the resident is independent on all of the mobility activities at the time of admission. That's all 15 items must be coded as 6 or independent on the PPS 5 day for the exclusion to apply. Like the change in self-care score, the calculations for admission and discharge require a bit of recoding if the code used for admission or discharge is a code other than 1 through 6. So the calculations use the same as for change in self-care score. If the code is between 1 and 6, use the code as the score. If the code is 7, 9, 10, 88, the item is skipped, dashed, or missing, then recode as 01 and use this code as the score. The sum of the scores of the admission mobility items are used to create an admission mobility score for each Part A stay, and scores can range from 15 to 90, with a higher score indicating greater independence. A point that I want to make is we often talk about dashes and annual payment update impact. Remember that APU is different from calculation of measures. So, although you may have an APU implication if you were to dash one of the GG items, the score for the measure is still calculated if you have dashed one of those GG items. I hope that makes sense. I'm hearing giggles. I'm not sure it makes sense. Observed change in mobility score is the discharge mobility score minus the admission mobility score calculated for each resident stay. The facility level average observed change in mobility score is the average of the observed mobility change scores for each resident stay, except those that are excluded. The measure calculations. Oops. Could you go back one, please? I think I was a little aggressive on the clicker. The measure calculations used in the change in function measures use both observed scores and expected scores. After you calculate the observed score for each resident stay, the next step is to calculate an observed change score and an expected change score for each resident stay and for the facility. So, for the expected change in mobility score, resident risk factors are used to calculate an expected mobility change score for each resident stay. Some of the examples of risk factors: age, prior functioning, primary medical condition, comorbidities, and the facility level average expected mobility change score is the average of the expected mobility change scores for each resident stay. So once again, you may be able to see an observed score in the change measure before risk adjustment. And since the measures were implemented, we've needed additional time and data to calculate the risk adjustment covariates. Now we're going to move on to the discharge self-care score. This measure estimates the percentage of residents in a Medicare Part A Type 1 SNF stay that meet or exceed an expected discharge self-care score. Expected scores are calculated and risk adjusted based on resident characteristics. Higher scores indicate a higher percentage of residents met or exceeded expected discharge self-care scores. The measure is a comparison of self-care observed score and calculation of expected score. An illustration of the calculation on the discharge self-care quality measure score is presented here on slide 35. Now, I referenced slide 35 just to make sure that those of you who slept over the past couple of minutes as I've been talking about these quality measures can wake up and find out we're on slide 35. The denominator is the total number of Medicare Part A Type 1 resident stays except those meeting exclusion criteria. The numerator is the total number of Medicare Part A SNF stays, type 1 stays only, out of those in the denominator, except those meeting the exclusion criteria, with a discharge self-care score that is equal to or higher than the calculated expected discharge self-care score. Once again, the numerator divided by the denominator times 100 will give you your percentage. For this measure, a higher score indicates that you had resident stays that met or exceeded the expected scores. For the discharge self-care measure, we have the same self-care items that were used in the change measure. They include eating, oral hygiene, toileting hygiene, shower, bathe self, upper body dressing, lower body dressing, putting on, taking off footwear. But you'll notice that in this example, we're referring to the discharge scores, or for the example of eating, GG0130A3, which is calculated from the PPS discharge. The response codes, if you could go back one slide, because I'm not sure you got it the past few times, include the 6-point rating scale. The 6-point rating scale is 01 through 06, any of the activity not attempted codes, as well as if the item is skipped, dashed, or missing. The exclusions. The exclusions for the discharge self-care score is if the Medicare Part A SNF stay is an incomplete stay, if the resident has the medical conditions of coma, persistent vegetative state, complete tetraplegia, locked-in syndrome, severe anoxic brain damage, cerebral edema or compression of the brain, is younger than 21 years old, was discharged to hospice or hospice while a resident, did not receive PT or OT services as indicated on the PPS 5-day, or is not a Medicare Part A beneficiary. What's unique about the exclusions is that in the change, we had the exclusions calculated if the resident was independent in self-care or mobility, but because this is a discharge measure, the independence on self-care and mobility on the PPS 5-day are not considered. And the calculations should look familiar. If the code is between 01 and 06, you use the code as the score. If the code is 07, 9, 10, or 88, the self-care item is skipped. If it's dashed or if it's missing, then the item is recoded to 01. Sum the scores of the discharge self-care items to create a discharge self-care score for each Medicare Part A SNF record, and the scores can range from 7 to 42, with a higher score indicating greater independence. For expected discharge self-care scores, resident risk factors are used to calculate an expected self-care discharge score for each resident stay. The examples include age, prior functioning, prior medical condition, and comorbidities. Each resident stay observed self-care score is compared to the expected discharge self-care score, except those stays that are excluded. If the observed score is equal to or greater than the expected discharge score, the stay is in the numerator. Then, the expected discharge scores are calculated using the intercept and coefficient values from the risk adjustment model, which includes resident stay level factors that we've discussed as some of the examples of risk factors. And a simple observed score cannot be calculated for the discharge self-care and discharge mobility score measures. Now let's talk about the discharge mobility score measure. This measure estimates the percentage of residents in a Medicare Part A Type 1 SNF stay that meet or exceed an expected discharge mobility score. Expected scores are calculated and is risk adjusted based on resident characteristics, and a higher score indicates that a higher percentage of residents met or exceeded expected discharge mobility scores. On slide 41, we have an illustration of how the discharge mobility score is calculated, which you'll note is similar to how the discharge self-care score is calculated. However, uses section GG mobility items for the calculation. So it includes in the numerator the total number of residents in a Medicare Part A Type 1 SNF stay, except those meeting the exclusion criteria, with a discharge mobility score that is equal to or higher than the calculated expected discharge mobility score. And the denominator, as we've seen in our measures so far, includes the total number of Medicare Part A Type 1 SNF resident stays, except those meeting the exclusion criteria. For the mobility score calculations, these should look pretty familiar. They include roll left and right, sit to lying, lying to sitting on side of the bed, sit to stand, chair, bed to chair transfer, toilet transfer, car transfer, walk 10 feet, walk 50 feet with 2 turns, walk 150 feet, walk 10 feet on uneven surfaces, 1-step curb, 4 steps, 12 steps, and picking up object. But as you'll note, as we did with the discharge self-care score calculation, the mobility assessment items use A3, B3, and so forth on the PPS discharge. The Medicare Part A stays for the discharge mobility score are excluded if the resident had an incomplete stay, if the resident had the same conditions that we've discussed previously, such as coma, persistent vegetative state, complete tetraplegia, locked-in syndrome, severe anoxic brain damage, cerebral edema or compression of the brain, is younger than 21 years old, was discharged to hospice or received hospice while a resident, did not receive PT or OT as reported on the 5-day PPS, and is not a Medicare Part A beneficiary. The same calculation procedure is used for the discharge mobility score as was used for the change in mobility score on slide 31. That is, if the code is between 01 and 06, you use the code as the score. If the code is 7, 9, 10, or 88, is dashed, skipped, or missing, recode to 1 and use this code as the score. Sum the scores of the discharge mobility items to create a discharge mobility score for each Part A SNF stay, and scores can range from 15 to 90, with a higher score indicating greater independence. For expected mobility discharge scores, resident risk factors are used to calculate each resident stay. We have the same examples: age, prior functioning, primary medical condition category, and comorbidities, and each resident's stay's observed discharge mobility score is compared to the expected discharge mobility score, except those stays that are excluded. And if the observed score is equal to or greater than the expected discharge score, the stay is in the numerator. Then, as we discussed on slide 39, for the expected self-care discharge scores, the expected mobility discharge scores are calculated using intercept and coefficient values from the risk adjustment model, which includes those risk adjustment factors and others. And a simple observed score cannot be calculated for the discharge self-care score and discharge mobility score measures. So you may wonder, why did I keep repeating a lot of that information over and over again? Because I'm sharing another secret with you, is that when I learned these measures, I needed to read it over and over and over to better understand it. For those of you who are interested in the technical considerations for each of the function change scores, they are a little bit more complicated than the calculations from some of the other measures that we've been accustomed to for many, many years. I would refer you to the SNF QRP QM Users Manual that you can access on the SNF QRP website in the Measures and Technical Information section page. It is a vast resource of tremendously helpful material to be able to understand how the quality measures are calculated. Before going through the entire manual, my favorite tip is to go to Chapter 7, which outlines each of the quality measures and the numerator and denominator criteria for each of those measures. It helps me to understand how the measures are calculated, and then when we get into some of the more detailed information, like covariates, risk adjustment, and the actual calculations for the measure, there's more detail in the preceding chapters. I really encourage you to spend some time with that QM Users Manual, put a bookmark on your desktop. I have several bookmarks to that same manual throughout my desktop, and I have found it inordinately helpful to being able to understand quality measures. I would expect that many of you are your facility experts in quality measures, especially for the QRP. And although you're very familiar and very interested in the APU, I really encourage you to now take some time with the quality measures to better understand the function outcome quality measures, as well as better understanding the function process quality measure, or the completion of all of the items on the PPS 5-day for admission performance, 1 discharge goal, and all of the discharge performance items, because it's gotten a lot more complicated, but I think a lot more helpful to all of us in understanding the variation in our facilities, the covariates, and how our facilities may be similar or different from other facilities, so that we can actually use those risk adjustment models to look at our resident performance and benchmark against our own performance to look at our resident population. The next measure we're going to discuss is the SNF QRP quality measure, changes in skin integrity, post-acute care, pressure ulcer injury measure. Data collection in the QRP for the measure percent of residents or patients with pressure ulcers that are new or worsened ended on September 30th, 2018, and data collection for this new measure, changes in skin integrity, post-acute care pressure ulcer injury, began on October 1st of 2018. The older pressure ulcer measure, percent of residents or patients with pressure ulcers that are new or worsened, short stay, was removed, I think, or will be removed from provider preview reports in August of 2019. So if you have not yet received your provider preview reports, and I can't quite remember the exact date that the provider preview report comes out, you'll no longer see the old pressure ulcer measure on your provider preview reports. And beginning in October, you'll no longer see that measure reported in the SNF QRP for Nursing Home Compare. However, the Division of Nursing Homes has adopted the SNF QRP quality measure, the percent of residents or patients with pressure ulcers that are new or worsened short stay, for the MDS 3.0 Nursing Home Quality Initiative Quality Reporting Program. However, in order for you to access that data, your MDS 3.0 quality measure reports refer you to the data on the SNF QRP. Eventually, that information will be going back to the NHQI site, but for right now, you've been accessing that information through the QRP. So let's take a look at the pressure ulcer injury measure transition. The percent of residents or patients with pressure ulcers new or worsened, the last quarter of data collection for the SNF QRP was Q3 of 2018, which was July through September of 2018. The last time it appeared on your provider preview reports was May of 2019, and the last time it appeared on your Nursing Home Compare for the QRP was July of 2019. That measure was replaced with changes in skin integrity post-acute care pressure ulcer injury, where data collection began on October 1st of 2018. You'll see it on your first provider preview report in the summer of 2020. Not 2019, but 2020. And the initial data display on Nursing Home Compare in the fall of 2020. Next slide, please. We'll now look at more detail for the new pressure ulcer injury measure implemented on October 1st of 2018. This measure is a cross-setting quality measure adopted to meet the requirements of the Impact Act, the domain of skin integrity and changes in skin integrity. The measure reports the percentage of Medicare Part A Type 1 SNF stays with stage 2 to 4 pressure ulcers or unstageable pressure ulcers due to slough, eschar, non-removable dressing device, or deep tissue injury that are new or worsened since admission. In contrast to the old pressure ulcer quality measure, the numerator for the new pressure ulcer quality measure includes new or worsened unstageable pressure ulcers or injuries. The changes in skin integrity measure is calculated by starting with the number of pressure ulcers or injuries at the time of discharge, M0300B1 through M0300G1, and subtracting the number of these pressure ulcer injuries that were present on admission at the same stage, or M0300B2 through G2. This measure, as I mentioned, is a cross-setting standardized post-acute care quality measure. And for this measure, lower percentages are better. A coding tip. The M0300B1 through G2 items are used for measure calculation. A pressure ulcer injury on discharge, so M0300X1, which means any of the M0300 items, that are not coded as present on admission in M0300X2 on the PPS discharge is included as a new or worsened pressure ulcer injury. And M0300X1 minus M0300X2 greater than 0 means that a pressure ulcer injury is counted as new or worsened. Welcome to quality measure math. They put an X in. And X just represents the variable B through G. For the pressure ulcer injury measure, Medicare Part A SNF stays are excluded if there's missing data or a dash on new or worsened stage 2, 3, 4, and unstageable pressure ulcers, including deep tissue injuries at discharge, or if the resident died during the SNF stay, which we know is a type 2 SNF stay. This measure is also risk adjusted for the following at admission: dependent or substantial maximal assistance for lying to sitting on the side of the bed in GG0170C, bowel incontinence at H0400, diabetes, peripheral vascular disease, or arterial disease, or low body mass index in the K items KO200A and B. Slide 54 is an illustration of how the SNF QRP quality measure, changes in skin integrity, post-acute care, quality measure, pressure ulcer injury is calculated. The denominator is the total number of Medicare Part A SNF stays, type 1, in the selected time window for residents ending during the selected time window, except those that meet the exclusion criteria. The numerator is the number of Medicare Part A Type 1 SNF stays for which the assessment indicates one or more stage 2 to 4 pressure ulcers or unstageable pressure ulcers due to slough, eschar, non-removable dressing or device, or deep tissue injury compared to admission. Again, divide the numerator by the denominator times 100 to get your percentage. If a resident has multiple Medicare Part A stays during the target 12 months, then all stays are included in the measure. Another coding tip. When coding M0210 and M0300, determine that the lesion being assessed is primarily related to pressure and that other conditions have been ruled out. If pressure is not the primary cause, do not code pressure ulcer injury in section M. And another coding tip, if a numerically staged pressure ulcer becomes unstageable due to slough or eschar during the resident's stay, the pressure ulcer injury is coded at M0300F on discharge and should not be coded as present on admission. And another coding tip, if a pressure ulcer injury was unstageable on admission, entry, or reentry, then becomes numerically stageable later, it should be considered as present on admission at the stage at which it first becomes numerically staged. However, if it subsequently increases in numerical stage, that higher stage should not be coded present on admission. Let's move on to drug regimen review. This measure reports the percentage of Medicare Part A Type 1 SNF stays in which a drug regimen review was conducted at the time of admission and timely follow-up with a physician or physician designee occurred each time potential or actual clinically significant medication issues were identified throughout the stay, admission through discharge. It was adopted to meet the Impact Act domain of medication reconciliation. And for this measure, higher percentages are better. And data for this measure also began on October 1st of 2018. This illustration on slide 59 of how the DRR measure is calculated may be a bit difficult to see. It may sound familiar that the denominator for the measure is the total number of Medicare Part A Type 1 SNF stays during the period. The measure uses all three data elements, N2001, 2003, and 2005, to identify the resident stays in the numerator. So, it requires a review of whether or not there were any potential or actual clinically significant medication issues found during the review in N2001 equal to 0, or if there were potential or actual clinically significant medication issues found during the review where N2001 is 1, then a physician or physician designee was contacted and prescribed recommended actions were completed by midnight of the next calendar day, where N2003 is coded 1. Or if the resident was not taking any medications, N2001 equals 9. And appropriate follow-up occurred each time a potential or actual clinically significant medication issue was identified during the stay, where N2005 equals 1, or no potential or actual clinically significant medication issues were identified since the admission, or the resident was not taking any medications, N2005 equals 9. We do get questions on the help desk regarding how is DRR defined. A drug regimen review includes medication reconciliation, a review of all medications a resident is currently using, and a review of the drug regimen to identify and, if possible, prevent potential clinically significant medication adverse consequences. The drug regimen review for the Quality Reporting Program includes all medications prescribed and over-the-counter, nutritional supplements, vitamins, homeopathic and herbal products administered by any route. For the Quality Reporting Program, DRR, it also includes total parenteral nutrition, TPN, and oxygen. And we'd like to note that the state operations manual requirements for drug regimen review are different from the requirements for the QRP. Another question that we frequently get is which staff members may complete a drug regimen review. We'd like to tell you, I think it should be you. And I bet you want to go back to your facility and say, not me, it's you. But the fact is that each facility delivers resident care according to its unique characteristics and standards. So each facility has to self-determine policies and procedures for determining for your facility who may complete the drug regimen review in compliance with your facility policy, state, and federal requirements. So make sure you refer to your state and federal facility policies and guidelines to determine who in your facility should complete a drug regimen review. Another question that we have frequently gotten is how often should we perform a drug regimen review? I'd love to tell you, but I can't. Because every resident and every facility is unique. So the providers each have to use their clinical judgment to determine when a resident's medication regimen is reviewed, including medication review throughout the resident's stay. I don't think that the drug regimen review quality measure has changed that, has it? You always use clinical judgment to determine when your resident's drug regimen review needs to be completed. The timing of formal and informal drug regimen review activities should be completed based on your resident's need, complying with state and federal regulations, as well as any facility policies and procedures you may have. Time for a Slido check. Which of the following is not a SNF QRP quality measure? A, application of percent of residents experiencing one or more falls with major injury. B, SNF functional outcome measure, discharge self-care score for skilled nursing facility. C, changes in skin integrity, post-acute care, pressure ulcer injury. Or D, application of functional outcome measure, change in mobility among long-term care hospital patients. Based on the Slido performance, I'm waiting for some of you to wake up and answer the question. The vast majority, obviously, has selected D, and that's the correct answer. Application of functional outcome measure, change in mobility among long-term care hospital patients is not a SNF QRP quality measure. We'll briefly review the 3 claims-based quality measures, and I wish we had more time to go into detail on each of these measures. For the SNF QRP, the data used to calculate these measures comes from claims, so there's no additional reporting that providers need to do for these measures. The 3 current claims-based measures in the SNF QRP are Medicare spending per beneficiary, or MSPB, discharge to community, or DTC, and potentially preventable 30-day post-discharge readmission measure, or PPR. In the resource box at the bottom of the slide, you'll find a link and reference for how to access more information on these claims-based measures in the QRP User's Manual. So briefly, the MSPB measure evaluates SNF providers' efficiency relative to the efficiency of the national median SNF provider. Specifically, the measure assesses the cost to Medicare for services performed by the SNF provided during an MSPB PAC SNF episode. The measure is calculated as a ratio of the price standardized, risk-adjusted MSPB PAC amount for each SNF divided by the episode-weighted median MSPB PAC amount across all SNF providers. So now you can see why I wish I had more time to go through these claims-based measures. The measure was finalized in the FY17 SNF PPS final rule, and no additional data collection is required by facilities except claims data submitted during the normal course of business. There have been exceptional MSPB MedLearn webinars on MSPB. I encourage you, for those of you who are very interested in the calculation of the MSPB measure, to watch some of those MLN presentations. They're often transcripts as well as a slide presentation, so it's very helpful. For discharge to community PAC for the SNF QRP, the measure reports the SNF's risk standardized rate for Medicare fee-for-service residents who are discharged to the community following a SNF stay and do not have an unplanned readmission to an acute care hospital or long-term care hospital in the 31 days following discharge to the community, who remain alive during the 31 days following that discharge to the community. And the community for this measure is defined as home or self-care with or without home health services. This measure was also finalized in the FY17 PPS final rule. Higher rates for this measure are better, and again, no data collection is required by facility other than claims data in the normal course of business. The PPR measure estimates the risk standardized rate of unplanned, potentially preventable readmissions for residents, and here we're talking about Medicare fee-for-service beneficiaries, within a 30-day window following discharge from the SNF. Beginning fall of 2019, CMS will display measure results on Nursing Home Compare for this measure. The measure was finalized also in the FY17 SNF PPS final rule. For this measure, lower rates are better. Like other claims-based measure, no data collection is required by facilities besides the claim data submitted during the normal course of business. As a reminder, CMS announced in October of last year, 2018, that the PPR measure would be suppressed and not available on Nursing Home Compare throughout most of 2019. However, you've been able to see it on your reports. CMS postponed publishing the measure in late 2018 to allow more testing to ensure that it provides a reliable, accurate picture of provider performance on quality, in line with CMS Meaningful Measures initiative to address high-priority areas for quality measures that will help improve patient outcomes while minimizing provider burden. The refinement will be reflected in the October 2019 Nursing Home Compare quarterly refresh and the August 2019 provider preview reports. The data submission requirements for the SNF QRP are quarterly data submission deadlines: January through March, April through June, July through September, and October through December. Remember, there is a final submission deadline for each of the quarters. All MDS data must be finalized prior to the final submission deadline for compliance calculations, as well as reporting on Nursing Home Compare. Rarely, there are exceptions to the deadlines, for example, a natural disaster. Slide 71 is my favorite slide of the entire presentation, which is the reporting timeline for quality measures implemented on October 1st of 2018. The measure collection began in October of 2018. Your first review and correct reports were available in April of 2019. Your first quality measure reports will be available to you in the fall of this year, 2019. Your first provider preview reports will be available in the summer of 2020, and Nursing Home Compare in the fall of 2020. I'm in deficit spending on my time here, but I just want to mention very briefly that the nursing home quality measures have been available on Nursing Home Compare since the fall of last year. There'll be a presentation later today on how to access those measures on Nursing Home Compare. So we've identified why we haven't identified, but what I'd like to say is that there are 4 purposes of the quality measures on Nursing Home Compare, and that they are to give consumers information about the quality of care and help them choose a nursing home or SNF, to understand the data related to common conditions in the nursing home or SNF population, to facilitate discussions with staff regarding quality, and give staff data to support their quality improvement efforts. So you've learned about the 11 SNF QRP quality measures, the key components, and the data submission deadlines. Finally, take a few minutes to record some action steps, and I'd like to give a little bit of kudos to Reader's Digest from this morning. Good educators share knowledge. Great ones make an impression that stays in their students' hearts forever. I hope that at least I've been a good educator. Enjoy the rest of the presentations.